All right. So I'm Jim Hanley, and on behalf of the Department of Epidemiology, Biostatistics, and Occupational Health, and McGill more broadly, welcome, Dr. Theriault, to this interview.
Good morning, Jim. It's a pleasure to be with you today.
Thank you. Yeah. So we'd like to mainly get some of your story, of your life, if you like. We want to hear how you came from medicine, or went from medicine into occupational medicine, and into occupational health and epidemiology. We'd like to revisit some of the items from your research career, which is very, very interesting. And I think a lot of your viewers will find that quite fascinating, because there's a lot of complete pictures of things in it. On top of that, and being a researcher, you were also one of the most dedicated teachers and serious teachers I've known. So we want to hear a bit about your teaching and pedagogical issues. And I think we want a chance to just hear, things you might not have covered in papers or in Congress addresses and so on. And there are items that maybe shouldn't have gone off the radar but have, and if we have time, we'll do that. And of course, we want you to look ahead and give any advice you can to people starting out in our profession today. So those are the main things. And I think in doing all that, we want a little bit also to kind of get your philosophy of life and what keeps you happy and content, and what obligations we all have to society and so on like that. But that'll come out, I think, as you talk. Now, I'm always interested, before we start in getting into medicine and getting into occupational, in your entry into life itself, not just into the profession. Huh?
You have to keep your left hand down.
Okay.
It comes in the camera.
Okay, yeah. So I'm interested in yes, a little bit of nature and nurture. So I'm interested to know how much education your parents had, and whether you were first generation or second generation university. So your own parents.
Well, my parents were, they were not professional.
Yeah.
My father was a mechanic in heavy machinery, making roads.
I see.
He was a blue collar.
Yeah.
And my mother was a housewife.
Yeah.
But she wanted her son. We were three boys, no daughters. Three.
Yeah.
And she wanted her son to have a education, to go to university and to have a profession.
I see.
She considered that this would be our heritage, and she pushed in that direction, and we all did.
All three of you did.
Yeah.
Exactly. Good. And okay. And so you began with the BA actually, and then went from there to medicine at the University of Laval, right?
Yes, that's correct.
Yeah.
That's correct. In those years, we go to what is today college.
That's right.
And after that, we will go to university.
Yeah. And so it's interesting to me that you get your MD at age 25 already. So, part of your life is gone already at 25. And then you did 1 year internship in Theriault, and then 3 years as a general practitioner.
Yes, I started my career as a family doctor, general practitioner.
Delivering babies, making house calls.
All these things.
Yeah?
But actually it was quite heavy work. I mean, we were working day and night.
Yeah, and I see you were a member of a hospital in Theriault, another one in Cap-de-la-Malden.
There were 4 hospitals in the region, and we tend to have appointments in the 4 of them.
I see. And then after 3 years as a family doctor, quite a virage, quite a turn in your career. And I'm very interested to know how that happened.
After 3 years, I had some kind of insatisfaction.
Yeah,
I felt that I needed to go a bit further. I needed to know more about other things.
Yeah.
On one hand, as a doctor, I was treating headaches and sore throats and pneumonia and these type of things. But I was curious. As a doctor, you see people with health problems, but you don't see how society functions, how society works. So these people, large part of the day, they were in factories, they were at work. But as a doctor, I was just there to I did not know.
Yeah.
I wanted to have a better understanding of how society functioned, what people were doing. I was fascinated by that.
I see.
And so after 3 years, my wife said, I think you should take a break and you should recycle yourself because you show signs of being tired.
Already?
Yes, already. And I looked for a specialty, what kind of specialty I should go. So the first one that fascinated me was neurosurgery.
Oh.
Because I, was very curious about how the brain functioned and why people were reacting the way they were and so on and so forth. So I went to a neurosurgeon and told him that I would like to go in that direction. He said, don't do that. Don't do that. You will waste your career. There is too many of us on the market. You won't have any place to work. You will end up in remote regions. So he turned me down.
I see.
But at the same time, just by chance, I heard that they were looking for an occupational health physician for the province of Quebec, which is fairly unique. What is this?
Yeah.
I picked up the phone and tried to find out what it was. And they told me, well, through a legislation, through agreement between Minister of Labor and Minister of Health, they have created in the law in 1944 a position called Occupational Health Physician for Quebec. Mm-hmm. And the doctor who is doing that is on St. Lawrence Street on the top floor of a shop where they make garment. And they said he will retire soon and we're looking for someone to replace him. At the same time, that turned up something in my mind. When I was a medical student, they taught us how to treat disease, how to identify disease, how to help people. And in so doing, one day, in one lesson, a physician told us, noise, hearing loss is a big problem in the community. And the reason is that there is too much noise in industry. Mm. So as a doctor, that struck me. Mm-hmm. How come we allow that to happen?
I see, I see.
I say, well, when people have lost their hearing, there is very little that we can do, but we could prevent it because there seemed to be too much noise at the workplace. And nobody is taking care of that. So believe it or not, it turned something in me. Uh-huh. And it fascinated me. And I said, why don't I try to do something along those lines? So when they were looking for an occupational health physician for Quebec, I applied. Uh-huh. In those days, we were 3 or 4 people to apply, but the other doctors were old one, close to retirement, and I was young. Yes. And so they told me, we're not used to have a young doctor who will apply for this type of job, but are you sure you want to do that? And I said, yes, I am fascinated and I'd like to do it, but of course you have to pay me some training. You have to pay my training in occupational medicine because there was no such program or offer here in Quebec or in Canada. So they agree, and they supported me for a training in one American university and ended up going to Harvard. Mm-hmm. And this is how I came into occupational medicine.
Right, and it was called, the master's was in industrial health, it sounded like.
That's correct. Yeah. That's correct. I did not go to Harvard for public health or for epidemiology or biostatistics. I went to their program called MIH, Master in Industrial Health. Uh-huh. That was a 1 year. Yeah. But of course it was loaded with epidemiology and biostatistics as well, as industrial hygiene and environmental concern and these things. Yeah. Yeah.
Were there any teachers or researchers there that are professionals that particularly impressed you or that influenced you even in that first year?
Well, I had the chance to have John Peters as my supervisor. When we arrived at Harvard, they will assign a professor to you. Yeah. And since I wanted to go in MIH, and he was kind of head of this stream, I was assigned to him. And he was a very good guide for me. He asked me, what do you want to do? And here is a program you should follow, and so on and so forth. When I went to Harvard, in my mind, I was going to occupational medicine. Yes. But soon I realized that this is not what was of so much interest to me, it was more occupational health.
Yeah.
Let me make a bit of a difference here.
We need some terminology here. Yeah.
Well, I was a doctor. I used to speak in terms of disease and the treatment and things like that, and avoiding diseases. So to me, it was really practicing occupational medicine.
Yeah. That's the practice every day.
Every day.
Yeah.
And a lot of, in those days, there were quite a lot of physicians working in industry who were doing exactly that.
Yeah.
Identifying the risk, and then doing physical examination of the workers so that they will not be affected by the risk, or allocated people according to their limits in the workplace. These are the activities of occupational medicine.
Exactly.
But through my contact with Professor Peters and colleagues, I became fascinated by the research work that they were doing, trying to identify causal relationship between exposure and effect.
Yeah.
And at that time, Professor Peters had a very large research project to investigate the health problems in the granite industry of Vermont in particular. And so I told him, would you allow me to work for you and with you, but at the same time that I will pick up elements of your research to write my thesis. So it was a deal. And this is how I learned epidemiology as a tool and industrial hygiene to bring the two to search for causal relationship. And so I wrote my thesis on this. I published 3 papers out of my thesis. But what happened is that in the years that followed, the NIOSH, the American government, picked up my work and changed the level of exposure in the standards for the workplaces. And so suddenly I realized that...
Very few people can say that after their thesis. Exactly.
Yeah, but when I was treating people, I was treating one by one. I was helping one individual. But there, through doing research with measurement of pulmonary function, X-rays, and also assessment of exposure at work, putting this together, I published, and the impact was so enormous.
Yes.
I mean, just by doing that, I had helped
the entire community. Yeah.
A lot of people, not just in the United States, but even elsewhere, because everybody was using the NIOSH standards to apply in industry.
Yes.
So to me, it's a big revelation.
Yeah,
and that brought me then to dedicate my career to doing this type of work.
I see.
So never minimize the impact of a research.
Yeah.
Never, it's enormous.
Exactly. No, that's a graphic illustration.
We have a wonderful chance of being a researcher.
Yeah, but I think people, we'll come back to this later, you have to pick something that matters, and you obviously picked something where it could have a big impact. Yeah, 3 early papers of yours, and it with quite an early impact, right?
Of course.
Yeah. Not everybody can do that. That's great.
Life sometimes bring you in a context where you can do it. I would not claim that at the beginning I initiated that. My instructor, my professor at Harvard, he was the one who had the contract. But what I'm saying is, as an individual, I realized suddenly that I will do much more by conducting research of that type than by doing my occupational medicine.
Now, you did that doctorate in record time. 2 years, to me, is really a record for getting a doctorate.
Well, I had no choice. I had to do it quickly, and so I really jumped into it and did it working day and nights and weekends and summertime. And because I told you that by going into occupational medicine here in Quebec, they would allow me to go to training in the United States. They would support me, but in return I had to give a certain number of years. Each year I will study. I have to give 2 years to the government and things like that. So in that context, I had to do it quickly. Everybody was in a hurry.
Yes.
And with the help of the instructors at Harvard, I succeeded. Peters and other people in the department helped me.
I see. So in the process, you became certified by the U.S. Department of Health, Education and Welfare as a reader in pneumoconiosis. Why was that?
My thesis really was about chest problems in the granite industry.
Yeah.
And so these people, they develop opacities in their lung. And one of my papers was to assess how much exposure it will cause, how many lesions, the size of the lesion, the speed, and so to do that I needed to read X-rays.
I see.
And this is how
these are standardization and criteria for
yes,
this?
there was a way of doing it, and we had to go through training to be able to read these X-rays. And so I did it for the sake of my my thesis.
Yeah. Is it still relevant today, this tool?
It has been refined, and oh yes, it is still used today.
Yeah.
It has been used thereafter
I see.
all over.
Yeah. Who else was in your class at that time at Harvard? Any names we still know? Who are your classmates?
My classmate.
Yeah.
Harvard has been, again, here, probably it's a matter of chance, but I ended up having wonderful colleagues like David Wegman, Larry Fine, and we...
You've stayed in touch?
We've remained in touch all over since then.
Yeah.
Every about 3 years, we spend 1 week together somewhere in the world.
They should make a movie about that.
And so in between those 3 years, when we need some advice or help, or we call each other, and they ended up assuming important position or responsibilities in their country or in the world. And so it has been extremely satisfying and rewarding contact with them.
Yeah. But Peters is the one who put you guys together, I guess.
Peter was the leader, of course.
Yeah. Okay. So then you came back then to Quebec because you had to pay back your training and so on. And you began back at University of Laval?
Well, first I came back to the government, to the Ministry of Social Affairs.
Yeah.
When I returned, I was invested with this responsibility of being the occupational health physician for the province of Quebec.
Wow.
With
the man had retired by this point?
Well, the man had retired by then, and I had a small office with 1 nurse and 2 hygienists and 1 technician in radio, a measurement of radioactive activities and things like that. So of course we could not do nothing. I mean that was out of proportion with the problem. But at that same time there was what I don't know if you remember that one, but there was a commission called the Gaston K. Neveu Commission, and they were considering a reorganization of I would say public health in Quebec.
And also medicine in general, I think. As Dr. McGregor, Dr. McGregor mentioned it as well. He had Castonguay here to try and
so it was a big thing.
Yeah.
And they divided the province into districts, and they created Département de Santé Communautaire, DSCs.
Yeah.
And there I was, and looking at the law, I said, and the reorganization that was taking place, I said, that's nonsense that things will stay the same thing for occupational health. Why is occupational health put aside and forgotten? So I went to see the minister and the deputy minister, and I brought my idea to them that they should take my responsibility and put this on the shoulder of the 32 head of DSCs along their other responsibilities in public health.
Right.
Well, they found this an interesting idea, and they changed the legislation, and so after a while I had multiplied myself by 32.
Are there now? Did they eventually get 32 people?
They invested these 32 people with the responsibility. Thereafter, other changes took place, new reorganization.
Yeah.
But then occupational medicine became an integral part of public health.
Yes, as it should.
And so they had to develop programs and legislation and so on and so forth. And it has had a major impact on the workplace here in Quebec.
Yeah, I see. Very, very, very interesting. So you had a lot to do with actually setting up the entire network of these then as well.
Yeah, well, yes.
Yeah, through that initial the initiative that with the minister at the beginning.
Yes. But then I slid from the government to the university. I was more of a university-minded person
by that
than
and you had cut
a public servant.
And I think the research fire had caught hold in you as well.
Research, and also at Laval I developed a teaching program, but that was a certificate in occupational medicine.
I see. Okay. And who was the dean at Laval, or the chair? Was that Rochon? Or that he came later?
At the beginning it was not. Rochon was head of the department.
Yeah.
Incidentally, maybe I had very close relationship with Jean Rochon.
Yeah.
We did our medicine together.
Oh.
Theriault and Rochon, R and T. So the first time I drew blood, it was from his arm, and he did the same thing from me.
Right.
So we were that close.
Yeah.
And so when I went to Harvard, he was there before me, preceded me, and I called Jean and said, well, I'd like also to go to Harvard. I have been accepted. And said, why don't you take my apartment? So I took his apartment in Boston.
So it's funny, you're saying R&T, you mean they're just the names and the list of the alphabet, is it that? That's what pairs you in medical school?
Yes.
Amazing.
And so when I returned, he had returned 3 years before because he had finished his PhD at Harvard when I started mine.
Yes.
And so when I returned, he was head of the Department of Community Medicine at Laval University.
Right.
And so he said, well, I'd like you to join the department, and we work
and you set up
together.
The teaching program.
When I leave Laval, then he had been promoted to Dean of Medicine.
Oh, I see. So your initial responsibilities at Laval were setting up a certification?
Teaching and research, the same thing as I have been doing at McGill.
Exactly. So now I just want to draw attention to your website. I don't know if the link will remain the same, but people can find you. We found this morning fairly easily. If we typed Theriault, it wasn't enough, but once we typed Gilles Theriault,
it came up from Google.
That's right. So, but I think it's a very nice summary of your research and your teaching, and I hope these links stay there for other people to look at later, and we'll make sure that we put the link in at the end. But I think you do list research first in that page, so I'm going to start with that, even though I think, honestly, my impression of McGill, they say we want excellence in teaching and research, but, research always wins at McGill. You are one of the few, I think, who could say excellence in both and really mean it. Most people, I think, will want to do their research and give less time to the classroom. You've been good to both, I think. So I'm going to start with research. And you have 5 areas there, bladder and lung cancer in aluminum workers, electromagnetic fields, and then others. And I suspect from reading through and talking to you that the aluminum industry research you did was probably the centerpiece of your career. Would you say that?
Yes, it has been a major piece of research.
And also
in my career.
another one, from what I can tell, where again you made a major impact. You're very modest, and you'd probably don't want to say, but I want to find out how all that got started. How did you get into the issue of the aluminum industry and what their problems are in workers and so on? How did that all start?
I was introduced to health problems in the aluminum industry first by Statistics Canada. Many years ago, Statistics Canada used to conduct epidemiological surveillance of cancer epidemiological surveillance throughout the country. And they will look at, of course, incidence rate.
By geography.
By geography, and by sex also, and by age. And they noticed that in the Saguenay region, there were limited rate of urinary bladder cancer, and that the ratio men and women was very different from elsewhere in the country. Elsewhere, I think it was something like 2.5 men for 1 woman, whereas in that region it was 9 men for 1 woman. So a major difference.
Something going on. Yeah.
And the epidemiologists at StatCan rose the question, could that be work-related? And at that time, I don't know through what channel, he contacted me.
I see.
And
where's the, just so for people who don't know Quebec very well, the aluminum industry was mainly concentrated where?
The aluminum industry was concentrated in the Saguenay region.
I see.
They had major plants there.
Yeah.
They had over 8,000 workers at that time. So the statistician at StatScan said, would you be able to and interested in searching this question? Of course I was interested. So the first thing I did, simply, I went to the population and did the standard case control study. Very simple. We identified as many cases of urinary bladder cancer that we could through tumor registry and so on. And then we use as a control the neighbor. Well,
how did you do that?
Well,
there's no random digit dialing in those days, right?
No. But we will find the street address of the case, and then we will go to the right side of his house until we find someone of the same age, the same sex.
Yeah.
And then we will just interview about where they work, what they are exposed to, and we had a questionnaire on the
occupational history.
Occupational history.
Yeah.
And also other things like if they were drinking coffees and all the risk factors that we could think of with regard to urinary bladder cancer.
I haven't asked you before, but what was participation rate like in those days? Was it easy to get people to answer questionnaires?
Oh, much easier than today.
Yes, you could ask. Yeah.
We had good collaboration. There were a few refusals, but not that many.
Yeah.
And people collaborated.
Because I think when people, this is one of the things today, that when people are asked, somebody knocks at your door and says, I want to ask you about something, and what's it about? About bladder cancer. Well, I don't have bladder cancer, sorry. So they'll let you go right away. So to get in and to tell people that people who don't have bladder cancer can help understand, that must be tough to say.
I'm not sure that we even mentioned bladder cancer. I think we just say we're doing health research. We were careful. It was phrased carefully.
Not to tip them off.
No, we would not put them on track. But
interesting.
So and by just analyzing it, we came up that there were more aluminum workers among cases than control, and more people who work in the pot room of the aluminum industry, because the pot room is really where there are reactors and where there are emission of a lot of pollutants in the environment. So that was the first step.
Yeah.
Then we published saying it's possible, there is a possibility, and we contacted the industry and tell the industry that we have seen this and that we would like to go further, but we cannot do that without their help. Not necessarily financial help, but help in terms of information, data. And they opened the door. They said, yes, we think we may have this problem, and if you can investigate, we will collaborate. And they collaborated beautifully well. So the next step, we conducted another case control study within the industry.
I see.
Since it was a large industry, since there was a lot of heterogeneity in terms of exposure between the workers, so it was possible to discriminate.
Very different jobs, you mean, and very different tasks.
Yes, yes. And there we really observe a very close relationship between bladder cancer and exposure to BAP, benzoaparine, and benzene-soluble matters. And also we observed that the excess was in some specific occupation, those that will really open the reactor and do their work, breaking the cross and sucking the aluminum and things like that. But by doing that...
With no masks or anything like that, no. I doubt it.
In the past there were no masks, but as we went along, the industry put in place a lot of protective measures.
Yeah, yeah.
Mask was one of them, and then they enclosed them into mobile habitats so that they will not even be exposed at all to the environment.
I see.
Anyway,
Yeah.
they really put in place protective measures.
Yeah, yeah, yeah. And their records were key to this whole thing, knowing how long each man had worked in what job. How extensive were their histories?
This is where epidemiology in occupational health is so interesting.
Yes.
Because we can have access to information that otherwise you don't have access. So on one hand, industry knows, and this particular industry knew where the people have been working, how long they've been doing it, on a matter of weeks or even days. So a person who would be breaking the cross during 3 years between 1960 and 1963.
Wow. So why do they keep records for that
They
long?
keep record because they pay them on a different scale.
Right, but
Okay.
once you pay somebody and your income tax is after 3 or 5 years, you can throw out your records. Why do they keep employment record?
They kept that. They
Yeah.
had this.
Wow.
At the
Going
beginning,
back-
it was just written on a little card, so each worker had a card, and the a different entry for each job,
I see.
each
Going back-
move within the industry,
So maybe going back 30, 40 years?
going back to their
beginning
first
of the-
employment, the beginning of
Wow.
employment.
I
So
see.
we had this. We could create then a fairly detailed history, occupational history of the person. At the same time, this industry, because there were standards of exposure they had to adhere to, they had engineers who measured two things, benzoaparine and benzene soluble matters on a regular basis in each workplace, each station, and so by, if you like, bringing this together, the
Yeah.
occupational history plus the chart of exposure. So we have all the working place, all the spot in industry, and in the other dimension, all the years, and we knew how much BEP there was in 1951, 1952, 1953 for those who were
Yeah,
crane operator or
yeah.
stud pullers and all that. So that was a beautiful set of
Information.
precise measurement of these two exposures. There were other chemicals in that place. They were not measured, but these two were measured.
I see.
And we had the occupational history,
Yeah.
detailed occupational history. So for each man, we created an index of exposure.
Uh-huh.
Quite, well, the more precise that you can imagine.
Yeah. No, go ahead.
And that allows us to study carefully the relationship between these exposure and this cancer.
Yeah.
And we saw beautiful dose response curve. After 15 BAP years, the risk would be 6, 7. After 50 BAP years, it will be in the 20s. You will rarely see in epidemiological study where there is such a remarkable dose response curve. So we could confirm to them that there was a problem. Would it be BEP that is the cause? Would it be benzene material? We did not know. These were the markers that we were using.
Yes.
It could be something else, but these are fairly good markers of the culprit.
Yeah.
So that's what we published.
I see. And then from there, then what happened? How did the industry handle it, or how did you propose then that?
Well, many things happened.
Yeah.
And one of them was the Workmen' Compensation Commission came to us and said, well, you did beautiful work. We have those response curves, but what do we do when we have with one individual who has a urinary bladder cancer? It's one way to doing it in the population with a dose response risk.
Yeah. You have a man
but it's
sitting in
another
front of you.
way to assess for one person, because in the population there are urinary bladder cancer. So at one point, can I accept that this cancer is work-related?
I see.
And so we had to design a way of transforming risk into probability, probability of causation. So there are techniques to do that, and well, we had a wonderful colleague, Ben Armstrong, statistician, very skilled, who allow us to do just that, to give the workman compensation a chart in which they will have all the level of exposure and the probability of causation. So they will just, when they have a worker who has, let's say, 50 BEP years of exposure, the probability will be 60% that this cancer is due to work.
caused by that, yeah.
And someone with 10 years of exposure, his probability will be 3%. So we provided them with such a scale.
Yeah.
And
what do they do with it? Do they use a cutoff of 50%? Or?
that is an interesting thing. We realize that as a scientist, we can provide the information, but these people, they have to make decisions based on different other concerns.
Yeah.
What are we capable of allowing? At what point should we compensate or not? Because our system of compensation in this country is yes or no.
I see.
We don't.
There's no fractions?
There's no fraction. We don't pay a portion of the
so it's not like
indemnization. You give it to yes or no.
So it's not like when you crash your car and they decide how to divide up the who pays for how much from which insurance company.
No.
It's one or the other.
It's a yes or no.
I see.
So they had to draw a line.
I see.
A line, when you are above the line, automatically you are recognized as having bladder cancer related to work, and once you are under the line, no, it's considered that it's more a personal...
background case.
Yes, background case.
Even though some of them are...
So in order to draw this line, then they created a committee of experts who discussed this different ways, and they made a decision. That's good. It's not a scientific decision then, it's a consensus decision.
I see.
This is how things work. Yeah. So this is one thing. Another thing that happened is based on what we have observed, when you have a dose response curve, there's a lot of information you can extract. And one of them is, what should we allow now in terms of level of exposure for the workers? Change the standard of exposures, change the norm.
Bring it down.
Bring it down, and how much down? To what level?
Yeah.
So when we started the study, the allowable concentration was 5 part per million. And when we published this, we recommended that it be lowered to 0.2 parts per million.
That's 25 times less, or 20
It's a lot less.
Wow.
But this has happened. I mean, it changed the norm from there on in terms of allowing exposure.
And how do they in the industry actually achieve that then? They have to put more controls in place and more isolation?
A lot more controls, changing the technology, changing many different changes.
Yeah.
Yes.
And
so
how many cancers will you still get at 0.2? There are still some cancers will be caused at that.
Okay. Here again, it's a bit of philosophical approach.
I see.
What can society consider as an acceptable risk? Because
you can't bring it to
zero risk does not exist.
Yes.
But what we put to them said, if you keep the exposure at 5, then you will have something like 180 cases per 1,000 workers after their working life that will develop urinary bladder cancer. Well, we recommend that you break this down to 1 case per 1,000 worker.
I see.
Looking at what is being done elsewhere in the world, we think that society is willing to accept this type of risk. So if you want to reach this risk, you have to lower your exposure to that level.
Got you. And that's what's happened. Any more on the bladder cancer before we move on to... I think that's...
Well, no, but let me tell you something that I like to mention. As when I was doing work in the aluminum industry, we look at more than cancer. We look at other issues. One of them was telangiectasia.
Oh, yes, of course.
The workers in that industry would develop red spots on their skin, and they will become worried about these red spots that have not been described in the medical literature. It was something new. And they also asked me to investigate this. And in doing this investigation, realized that here in Quebec, we had 2 ways of making aluminum. We had the pre-bake process and the Soderberg process. And my question was, could the difference in exposure explain that
who's getting
the spots?
Yeah.
But the problem is that here everybody had worked in the 2 technologies.
Oh.
So it was very difficult to...
People jump around, or there's...
Yes, yes. Well, even in some plants, they have changed the process over the time and things like that. So I asked the company, is it possible that I will go to a place where they use only the pre-bake?
Yeah.
Because here we have a mix of pre-bake and Soderbergh, and I suspect that the problem exists with Soderbergh, but I am not sure with the pre-bake.
Yeah, you have to separate them.
And they said, oh, we have a plant in Linemouth. Linemouth is either in England or Scotland,
At the boundary?
at the border, at the boundary between the two.
They have just the one?
Yes, this
process.
one.
Yeah.
And so they said, okay, we will pay your trip and please go and do a little bit of investigation in Linemouth. So I went to Linemouth, and when I arrived in Linemouth, I went to the medical office and I told them that I was doing research, and I thought they were aware of that and they had given the okay.
Mm-hmm.
But the doctor said, no, you're not allowed to go in the factory. You're not allowed to go to the shop plant because that will disturb the process. So we'll allow you to sit in the doctor's office when a worker come, and then you can look at the skin to see if they have red spots. Well, that would have taken me years to cover because I
want to just wait for them to show up.
wanted my goal was to.
They can show up with a cold or anything. I mean, yeah, it does not do that.
I wanted to look at a minimum 500 workers.
I see.
And so I was very disappointed.
Yes.
I did it one day and 2 days. And what the hell?
Yeah, you're not getting very far.
So one morning I spoke with the nurse. And I explained to the nurse that it's nonsense. I will never succeed in doing that. And I had a mandate to accomplish. And by speaking to her, I don't know why I missed it before, but she mentioned that people were having their shower after work at the end of her shift.
Yeah.
And there were 3 shifts. And so why don't I go to the shower? And I did. I mean, at the end of each shift, I would go and have my shower with them.
I see.
They were all there naked taking their shower. And I tell them that what I was doing, and they would all line up and be very happy to show me their skin to see if they had the red spots.
Exactly. Wow.
And so that way, within about 8 days, I was able to have as many workers as I wanted.
My goodness. Did you publish that too?
No, this is not published.
Yeah.
Epidemiology brings you in awkward situation once in a while, doesn't
No,
it?
not that, but did you work out who was the culprit, which one of the two?
Well, they had no telangiectasia in that pre-baked plant.
I see.
So that was
It
an
must be the
important
other
piece
one.
of information for me.
Yeah.
I got that one.
Yeah.
But at the same time, I was surprised. These people over there, they had little warts on their skin, little white warts.
Yeah.
A lot of them. And so they will come and show, look at this one, look at this one, what is this? And they were curious about this. Very likely, I think it was due to coal tar pitch. And also, one worker one day told me, you know, I have to, when I will cut my grass, I have to open my umbrella. I cannot cut my grass without...
What?
Because it was exposed to the sun, and the tar is very irritant to the skin. And when you are exposed to tar and you go to the sun, the UV lights will create a skin reaction, inflammatory skin reaction. Actually, this is used as a treatment for people with psoriasis.
I see.
People with psoriasis, we give them a cream that has tar in it, and then we expose them to UV light. So it is the same thing. But so I was quite impressed by this expression that I need my umbrella to cut my grass.
My goodness. So that was quite a story. Now there's many more. We haven't time to do all of them, but the electromagnetic fields was another important part of that research on the hazards there was another important part of your research career. So maybe we can spend a little while discussing that.
It was.
Yeah.
It came out in the element industry. We knew that there was coal tar pitch volatile. We knew from other contexts that this has causes cancer in workers. But with electromagnetic field, we did not know anything.
Yeah.
It all started with a study by a lady in
California, I think, is it?
no.
Utah, maybe.
No.
We should have looked.
Ah, boy.
Yeah, we'll put it in after. Yeah.
Colorado.
Okay.
In Colorado.
Yeah.
It's a pediatrician. This woman, she was interested in understanding leukemia in children. In fact, she had the impression that maybe leukemia in children was caused by something in their environment. And she started, every time there was a case of leukemia, she would drove to the living place of the child and takes notes.
Mm-hmm.
What is the traffic light there? How many cars in case some pollution from the car will be responsible.
Yeah.
Is it heavily populated? So density, population density. Is there a factory around? Could there be pollution from factory?
Yeah.
The level of the standard of living, is it a poor environment or a rich environment? And she also started taking notes of the wires around the house.
Yeah.
The distribution of wires, and also the type of wires. Is it a drop? There are different ways of assessing the amount of energy that is in a wire and the current and things like that. So she also took note of that. And after a while, in a case control approach, she came up that children with leukemia live in houses where there are more exposure to the wiring. And she contacted a colleague that was a physicist, and they created a scale of exposure out of that. And so she wrote that children in houses more exposed to electromagnetic field had a higher risk of their leukemia associated with this.
Yeah.
So that has triggered a major worry all over, at least America, not to say the world,
From the
by the electrical power industry.
Yeah.
And the electrical power industry created a research institute, the EPRI, Electric Power Research Institute. And they invested money, and they gave this institute a mandate to find out. So here in Quebec, Hydro-Quebec came to me and said, would you do the study for us? And we ended up doing a very large study with all the employees from Hydro-Quebec, Ontario Hydro, and Électricité de France. Because the risk being very low, I needed a large population.
Yeah.
So I ended up having 120,000 electrical utility workers. Wow. And we did in the electrical industry about the same thing as we had done in the aluminum industry, assessing for each worker level of exposure.
That I remember you had to have, you had meters on people.
Oh,
right?
yes, we had not only that, but the meter had been designed specially for our study.
Is that right?
Yes, and the meter will measure electric field, magnetic field, and a third dimension that was called pulse electromagnetic field.
And they had to wear it for a week or 2 weeks. I remember.
For a week.
Yeah.
The worker will wear this for 1 week.
And then you give it to another one.
Exactly.
Yeah.
Exactly. That's how we assess exposure.
Yeah. And but how did things work out then? It wasn't as clear as the aluminum.
Exactly. I mean, we did not observe a clear relationship. In fact, we made a few observations that will create questions.
Yeah.
But at the same time, and this is the important point that I want to mention, while I was doing this in Quebec, other people were doing same thing in the United States, other people were doing same thing in Europe, and EPRI will bring us together.
Yes.
And I realized that by bringing different disciplines, there were not only epidemiology, there was cell physiology, there was physics, there was many different disciplines all together around the question was extremely rich.
Mm-hmm.
This has been a wonderful experience. Minimum twice a year we will meet. We have some 3-day conference on this.
Yeah.
Every researcher will tell where they are, and there will be discussion, what does this mean in terms of causal relationship, but not just on the point of view of an epidemiologist, but also point of view of a fundamentalist, toxicologist, physicist, animal studies. I mean, they were exposing a lot of animals. So that is the way, I think, to address a question when we have a chance to do it together, not in isolation.
I see.
That makes it extremely more capable and powerful and stimulating and all these things. But this particular question ended up to having no really
but there was
clear answer.
Yeah. I mean, we're now concerned that there's much more that's even happened in our environment since then, the last 30 years with Bluetooth and Wi-Fi and all these other broadband stuff now. People are even more worried, and the enemy is even more invisible in a way, right? I mean, it's a very tough area to study. Yeah.
In the last 30 years, I would say, man has mastered the use of non-ionizing energies.
Non-ionizing.
Non-ionizing. Before we knew about ionizing, X-ray. But the non-ionizing became mastered by men in the last 30 or 40 years and has improved our quality of life a lot. I mean, today you do a lot of things.
Look at your microphone going to the camera, wireless.
Microphone, cell phone, distance control.
Microwave oven.
Whatever. I mean, it's amazing the changes that have taken place.
Yeah.
Well, it's not, we don't see it, we don't feel it, we don't smell it, but it is there. Mm-hmm. We can measure it with machinery, we can measure it with monitors. And so if we could see this invisible environment, this invisible landscape, of course we will be stunned by it. Mm-hmm. But does it mean that it has some impact on your health?
Yeah.
We have absolutely no sign that it does.
I see. And there's lots of looking, is there?
There is a lot of looking.
Yeah.
Another thing is we must realize that the electromagnetic spectrum is very large. It starts with extremely low frequencies to ionizing radiation to extremely high. And in each section of the spectrum, these frequencies have a different characteristics. One of them will be the light. One of them will be the UV. One of them will be the radar. Mm-hmm. And I don't think we should put this together. I think we should keep studying them separately because we know they have different ways of affecting the body.
Yeah.
But this being said, in general, with the level at which we are exposed, we have no sign that it affects us.
And as I say, there's a lot of looking and very little evidence so far of any damage.
Exactly. Exactly.
And you think it's been long enough that we've had cell phones now and enough people have used them for long enough that if there were to be something, a signal, it should have shown up by now, or what's your impression?
If there was a significant impact, we will know.
By now.
If it's a very minor one, we may not have reached enough
experience
and back.
I see.
Yes.
Yeah. Now, going back a bit, you mentioned now this business of the collaboration and the various disciplines involved in this. But to me, the one that always struck me when you talk about in the bladder, in the aluminum one, is the hygienist was an integral part of doing occupational research, right? Do you consider them an essential piece, or how does that work? You have epidemiology tools, and then is the hygiene person one of the tools, basically, of what you're doing? How do you see it?
Epidemiological research in occupational health is really working toward unveiling causal relationship.
Okay.
For a causal relationship, you need two pillars. You need the disease, well identified, clearly diagnosed.
Yeah.
But you also need an assessment of exposure. And this exposure has to be well done. This assessment has been well done. And this is why the industrial hygienists are so useful.
Yeah.
We also consider that the work environment is a fairly closed environment where you can measure these risks.
Yeah.
But let me here point something that before going into this field, before the first time I went to the shop floor in industry, I had a vague notion of what the risk was. But the first time that I accompanied an hygienist, it was in a factory where they make fluorescent tubes.
Yeah.
And when you make in a fluorescent tube, you put 2 drops of mercury inside, so that the current will create light. Well, the workers, once in a while, they will break the tube. They will. Sometimes there is a weakness in the tube. Sometimes they will. So it will break. What happens is that mercury will drop on the floor. But at our pressure, atmospheric pressure, mercury will vaporize. And then the workers will become poisoned with mercury. So what this did to me, it made me realize what the risk is.
I see.
It's not something.
You see the enemy face to
it's
face.
not an intellectual concept.
Yeah.
It's something very concrete.
Yes.
And so at the workplace there are very concrete risks, measurable risk, and this is why hygienists is so important.
I see.
They know what the risk is. They measure the risk. They can quantify the risk, and then you can look at if this risk has an impact on health.
I see. Now, we could have come back later on, and in many other interviews, people talk about working with industry.
Yes.
In the pharmacoepidemiology area, we've already discussed it with some people as to how it is to work with industry. How you've worked a lot with industry, and you know it has a bad name with some people. It'll corrupt you and so on. But I have a feeling you have great respect for industry and how it works. So how do we separate out this?
Well, first let me put this in a concept of occupational health research.
Yes.
It's almost impossible to do occupational health research without going in industry.
Right. Yeah.
And the information is there.
Yeah, and they welcomed you in, which is the surprising thing. Yeah.
Well, it depends on what the question is.
I see.
An industry that has a health problem with its employees that is work-related, this industry normally will want to solve the problem, will want to understand the problem, and will want to bring a solution to it. Yeah. They don't want to cause damage to the health of their employees. And this is what has happened with my example in the aluminum industry. They knew there was a problem. They wanted to describe, to identify, to master it so that they can manage it well. But that problem had nothing to do with their product.
I see.
When you touch the production of industry, it's a lot more difficult, more touchy. Let me go back to the example of asbestos, because asbestos and lung cancer and mesothelioma has been a very big issue. When my colleagues went into the asbestos industry, it is because asbestos realized that they were having health problems with their employees.
I see.
And they wanted to find solution and to identify it and to solve it.
Yeah.
But this asbestos industry, their product was also asbestos.
Oh, what they sell later, yes.
What they sell later. Yeah. And then here you have a kind of a double, how can I say it? You are caught between, on one hand, solving a problem, on the other hand, protecting the industry, because by saying asbestos causes lung cancer, how can this company keep selling asbestos to the public?
Yeah, because when I have my aluminum laptop,
yes,
that's fine. I don't have any danger with that.
Absolutely,
right?
because in the aluminum industry it was coal tar pitch.
Yeah.
Well, coal tar pitch has nothing to do with the product that is aluminum.
That's right.
But asbestos was very different.
Yeah, I see.
And so I understand that all
these are mixed up in a lot of people's minds, you think? They don't realize the difference? Yeah.
I think when you want to assess the work of a researcher, you must make this point that, well, when the researcher is working on an exposure and an effect at the workplace for the workers, there is no pressure of no pressure to be biased one way or another.
Right. Yeah.
But it is, as I say, different in the other context where there is a lot of interpretation that came up afterward.
Yes.
That may give an image to the researcher that is completely wrong.
I see.
We can kind of raise a suspicion that the researcher has been biased.
Yeah. Yeah.
Which is not the case because it was not even the context in which he or she did the work.
I see.
I think we must be
that's,
careful when we put the judgment.
But that's a very helpful distinction for me that I hadn't have to realize before, myself even.
I hope I'm making clear enough.
No, very clear. Yeah, absolutely, absolutely. Now, just one last thing on industry before we move on to teaching. How does industry work with the compensation boards and so on? How does that work out? Do they, when you talk about, are there premiums they pay, or how does it work?
Well, workman compensation scheme are different in each jurisdiction. Difference in Quebec versus in Ontario, and also very different from in United States or in other countries. So here we really are regional, if you like.
Yeah.
Here in Quebec, workman compensation is an employer insurance.
I see.
It has been created to protect employers against lawsuit that will jeopardize their industry.
So I see. So they pool just like industry.
All employers are obliged to contribute, and the money is used by the CSST to apply a set of rules to the victim of a work accident or a work disease, and so on and so forth. In so doing, our legislation have taken away the right of an individual to sue the employer.
I see.
So this is the deal. We create an insurance, they handle that, they protect the workers, but the workers cannot sue and have judgment against an employer. Unless, well, there could be exception. So that's our system.
I see. And is that the tribunal that you sometimes work or help out in?
That's another part of my career that I am very happy with and fairly unique. When I was at Laval University, a long time ago, 1977, there was at that time a commission that was set up called the Commission des Affaires Sociales, CAS. And the CAS was created by the Minister of Health as a kind of a buffer between the administration and the people to decide on issue where there was disagreement. And this commission administered several legislation. And one of them was appeal in occupational accidents or occupational related health problems. So we were an appeal tribunal.
I see. Who appeals? A worker?
Pardon?
An individual worker appeals?
Oh yes.
I see.
And also an individual company. I mean,
either way.
Either way.
Either way.
It's a tribunal.
I see.
At that time, the CAS received the jurisdiction to administer this law, and they were looking for occupational health physician, and they invited me and one in Montreal.
I see.
And they gave us the statute of judge. I mean, we are sworn as judge. Same thing as, and when we sit with a lawyer, but we render decision. That's a fairly unique system.
Yeah.
We don't have that many
Yeah.
non-legal people who are judged in Quebec, but this one
I think
is
the
a
only
case.
other one I saw like that, there's one in the United States, there's vaccination judges that settle individual cases of vaccination indemnity as well.
Yes.
Yeah, but it seems, and some of them are engineers, some of them are others, but they're sworn in as judges.
Yes.
Yeah.
Yes.
How many, do you do a lot of cases? How many cases a year do you have of that? A lot that you have to handle, or?
We lost this jurisdiction in the 1980s because they created a new tribunal called the Commission des Lésions Professionnelles, CLP. But I remain in the tribunal, and I now sit mostly on car accidents, cases that are more related to car insurance cases.
Yeah.
But it's extremely
well, it keeps you on your toes, I imagine, right?
Yes, we face real case, and we have to
study them.
scratch our head
Yeah.
to decide who is right, who is wrong, because usually it's difficult cases that are brought to
and
us.
again, there's no division. It's got to be black or white, one way or the other. There's no
The
sharing.
tribunal, unfortunately, has to settle.
I see.
There will be a winner and a loser.
And no sharing.
No sharing.
Wow. Okay.
Although they have also created, we are maybe going a bit that's outside of my domain, but they have created a conciliation service.
Yeah.
So when someone apply now, they will first go through conciliation. And if they fail in conciliation, then they come to the judge, and the judge has to decide.
I see.
But this is something.
Well,
this is something that I like. The fact that I am an epidemiologist has helped me a lot.
Yeah.
But also it has allowed me to realize what is appreciation of the evidence. I mean, what we do as a judge, we listen to the person, we assess what there is in terms of evidence. We look at the law, what the law says, and we have to interpret the evidence versus the law. So causality in front of in a tribunal is a bit different than causality in epidemiology.
Yeah, absolutely. I think a lot of people run away from medicine into epidemiology because they don't want to deal with individual cases in medicine. A lot of epidemiologists tell me I want into epidemiology because a proportion is fine with me, but I can't stand the probability for one patient, one or the other. But you've done both now, it seems to me, right? In your epidemiology, or an aggregate person, and in your physician.
The point I will nuance this a little bit, Jim. Epidemiology, I mean, we are very rigorous in saying there is a causal relationship.
But it's an aggregate.
In front of the law says any reasonable person. So you have to decide on the existence of a causal relationship based on what any reasonable person will arrive at as a conclusion.
I see.
So sometimes it's a bit frustrating. I'll give you an example, a very interesting example. I also sit for vaccination. We also have the law to decide if the person is a victim of vaccination.
Yes.
Okay.
The person, have that here too?
We do.
Okay,
and we administered this law.
Yeah.
So a person come in, he had a flu shot. 15 days later, he developed a neurological disease.
Yeah.
And we look at the epidemiological literature, and it will say, well, we cannot confirm or we cannot reject, there is not enough evidence.
Oh boy.
But as a judge, I have to make a judgment.
Yeah.
So, I mean, what a reasonable person will do in that case. Here we have on one side the science, on the other side the reasonability of a person.
Gilles, I think we could continue for hours on the research side, and maybe we'll have to set up some more. But I do want to, because you're so special that you had such a strong research and an important research career, but also you're one of the few at McGill who's taken teaching as seriously as I've seen it, you take it. Really, you've been ahead of that as well. And just today when we were going through the interview, setting up for the interview, Stuart told us that he saw you here 25 years ago doing videos for distance education. So I will spend the rest of the time now on your teaching side of your career. And first you set up a program in Laval for occupational medicine, right, a certification program. Then you came here, you set up a research program, a degree for research programs here at McGill. Do you want to say a small bit about that, or just a little bit? It was a...
Yeah, well, when I came to McGill,
Yeah.
I told McGill that I would have liked to develop a graduate program
Yes.
in teaching, master's degree and PhD degree in occupational medicine at McGill.
Yeah.
And they've been extremely supportive, more than my previous university. So they helped me to go to the Ministry of Education and to the CRIPUC and these different places, and we made the case
to get the program approved.
Yeah, to get the and we had first a temporary approval and then a permanent approval. That was fantastic. But remember, Jim, I am occupational health physician. I am a believer in occupational medicine, believer in occupational health, and I knew that a lot of people wanted to have training in this.
Yes.
Physician in industry, nurses in industry, industrial hygienists, they were all over. They did not have access to higher education.
Right, and they're already started their families and careers and...
Exactly. So my fight and my goal was to bring them higher access to higher education in their domain.
Yeah.
And I first started by opening the program here on campus.
Yeah.
But people could not come because of their family and occupational responsibilities and duties. At that time, there was something fairly popular which was called summer program. So I turned my program into summer session and invited people to come in summer session. But people in summer, they like vacation as well. I mean,
Sure.
they will not come that well.
No.
So I tried something else. I said, okay, instead of teaching by term, I will teach by module, and we will create 2-week modules, and people could build up their master's degree through these 2 weeks module. And that was a bit more successful. So for a couple of years, 2 or 3 years, we offered our teaching here on campus, intensive teaching 2 weeks. And students registered in the program will build up their master's degree this way. But then I came across a professor at the Faculty of Education, and he told me that he had set in place distance education for people who wanted access to program but could not come, particularly professors in remote regions in Quebec and even the rest of Canada. So he had developed a distance education technique based on paper and faxes and telephone conferences and these things, because in those days internet was not that developed.
That's right.
And so I like it very much, and I started this type of distance education on paper. But soon internet came in.
But you were there before it, I remember that. I remember boxes of material going out from your office.
Exactly.
Yeah.
You had the kit. We would send a kit to
So
them.
it would have printed materials,
printed.
Video. I know you did videos here at McGill that were part of that.
Yeah, that's how I came first to shoot videos here.
That's right.
Videos on tapes. I mean.
Yeah, yes.
On VHS.
The young ones don't know what we're talking about.
Yes, okay. We did that. But my goal was to bring education to this market, to these people who wanted it, who needed it.
Yeah, I see.
And of course, when
the internet came, it was a godsend, huh?
Yes, WebCT at McGill has been a wonderful tool. I don't know if they still use it, but at that time it was WebCT.
Yeah.
McGill has an IT group that was very open and supportive and helped me.
Yeah.
At one point, I went on sabbatical leave, but my leave I took here at IT with the people at IT, and so I developed more skill and understood better
Yes.
and so on and so forth. And it become distance education. I think we were a bit pioneer
Yes,
in this
you
type
were.
of distance education.
Yeah, yeah.
The philosophy that I had is that these are serious people. These are people who need this type of education. So I don't have to
Convince them. Yeah. Yeah. Motivate them.
motivate them.
Yeah.
But I need to guide them. So
Yeah.
I see myself as more a resources for them.
Yeah.
And I provided them with objectives, with material to do exercises to reach those objectives. I put self-evaluation techniques in the system. We had forums, regular forum of exchanges with the student, so on and so forth. And I brought them to McGill for 2 days per course. So if they take one 3-credit course, they had to spend 2 days with us at one time during the term, so that we will complete during those days things that we did not do at distance.
There were some things I remember you said that you could not do, physical exams and things like that you actually show them here on live, right?
Well, I give them, for example, a course in occupational diseases.
Yeah.
And so when they came, I had minimum 6 to 8 people with the disease.
Yes.
And for the first day, they will interview the person, they will carry physical examination, and during the evening he will prepare a summary and their views.
Yeah.
And the following day, the specialist will come. So if it's a case of skin disease related to work, the dermatologist will be here the following day to challenge them. If it is a case of chest disease, the pneumologist will be here, and so on and so forth.
Yeah.
So these things we couldn't do at distance.
That's right. That's right.
The hygienists, they will bring the student to a factory and they will guide them through an industrial hygiene survey within the factory. So that completed, if you like.
Yeah.
I think we did a good job. I was pleased with my distance education.
Absolutely. Yeah. And what I remember you being so ahead of the curve that you had the idea of discussion groups, chat forums, and so on, well ahead of their standard now, I think, in WebCT. But,
yes,
but
as soon as the tool existed, we had to use it. Yes.
Yeah, yeah. But then how did they talk to each other one-on-one, or did you have a lot of emailing back with them, or how did it work?
It was not emailing. It was a bulletin board, if you like.
I see.
So
electronic.
Electronic.
Yeah. And you spent...
Well, the professor will put a question at the beginning of the week.
Yeah.
And student will interact during the week, and the professor
everybody
will interact
sees
with
everybody else.
Everybody saw everything, every exchange. We
see.
had this facility with WebCT.
Yeah, yeah. And in fact, in terms of contact hours and in terms of writing and communication with them, you probably spent a lot more hours doing that than you would on a classroom version, did you?
Well,
I would guess.
This has been, it was time consuming.
For you?
For the professor.
Yeah.
It was time consuming. And
yeah.
perhaps just some people found it too heavy.
Yes.
Because yes, it became heavy.
Yeah.
But one way around this was to try to have some assistants, teaching assistant. When the class is big enough, we have a teaching assistant who will...
Just to keep up.
Yes.
Yeah. So, and now, out of curiosity, could you teach? Are there certain limits to what you can teach by that system? Do you think I could teach a statistics course by distance, or do you think you need?
Oh, we had a statistics course, and depending on the instructor, didn't like it or did not like it. I guess
that's the case in the classroom too.
You know, I think in statistics you have beautiful modules, you have beautiful exercises, you have beautiful units.
Videos.
Yes.
Yeah. So
yes,
no
I
reason
think
why not. Yeah.
I think statistics can be taught easily with this technique.
Yeah, I think many of us think that we're indispensable and we have to be there, and I think we probably are wrong. Right? That we have to be there with them really live and so on.
What's your philosophy about teaching? Some teacher believe that speaking in front of a group is very important.
Yeah.
Other, and I was among them, I provide them with the resources and they do their education.
Yes.
And that's the difference, I think. If you go on distance learning, you have to adapt the philosophy of it is a student. I will provide the mean to this person. This person wants, is motivated, and then I will help her or him.
Yeah.
And I
of
will
course
avoid speaking or giving a conference in front of people.
Yeah, yeah. But again, they're motivated, and that's a big difference, right?
That's a big
That's it.
big
I think
difference.
undergraduates at 18, this probably wouldn't work, right? So, okay. Now, let's just move on towards the end of. I have here a category called awards and positions. I do want to ask you. It's already come clear you're very, I think, very satisfied with the work and the award and the internally. You know, the satisfaction you've had from all of these academic exercises. It's clear to me you've enjoyed it. You get great, immense personal satisfaction for it. But others have also recognized that, your contributions. And I know there's a number of awards you've gotten. Maybe you want to just tell us the ones you're most proud of. Come on, Gilles, you shouldn't be modest at this point, really. I mean, we all, have internal awards, but I think you should mention some of the ones that you got from outside bodies as well.
Well, of course, just before I retired, McGill recognized my contribution to teaching, as excellent in teaching award for my career.
Yeah.
Of course, I was
You were
very pleased with that.
Yeah.
One thing that happened a couple of years ago, in Canada we have the Occupational and Environmental Health Society, if you like. That regroups all the occupational health physicians. And they also gave me a career award for my contribution to education.
I think if this is Hollywood, it would be the Lifetime Award, right?
A Lifetime Award for my contribution to occupational health and safety in Canada.
Yeah.
And when they were awarded, when they gave me the award, it was during the conference, and there was maybe 200 people in the room, and the speaker said, all those who have taken classes from Dr. Theriault, would you raise your hand?
Mm-hmm.
And more than half of the audience raised their hand.
My God.
I was impressed.
Yes,
I was touched by that.
Yeah.
And you realize that, as an educator, particularly in a university like here, your students, a kind of a prolonged, how can I say that? It's a self. I mean, you find yourself a bit in them.
I see. And passing yourself on to them, you mean?
Well, yes. You've been giving them your own views. You've been giving them your belief. You've been giving them the way you think things should be done.
Yeah.
And then you realize that they are doing it for you.
I see. I mean, you've passed the torch on.
It's an extent of self.
I see. Yes.
And I think as an educator, we should also realize that.
I see. Because it came to me the other day, maybe a couple of months ago, we lost somebody, Jean-Pierre Theriault.
Yes.
And I was saying to somebody that it's a pity that I hadn't got to interview him before he died. And I said, I'm sorry that there's a number of these people I want to do that with, but I better hurry on. And the other teacher said to me, no, don't worry. We're constantly passing on his messages. The ones we have received, the messages we've got from him, we're constantly doing the same thing now to the next generation.
This is so true with Dr. Farah. I mean, he has had a major impact through his student who loved him.
Yes,
in fact.
yes,
He's been very dedicated to them. He has given his student a lot of himself.
Yeah.
And today, I mean, they are all over the country, all over America, these students.
And people people know who Dr. Farah was. He was what was he, industrial hygiene?
Yes, he was the head of industrial hygiene group in our...
The one connection I had with him was through Robin Tamblyn and Dick Menzies when we were doing the sick building syndrome stuff, where he measured, I guess, I don't know what you call it, agents at the workplace, at the desks of everybody in these offices. And he was quite something. So that's, and then you also got invited to Japan to be a visiting professor.
Yes, this has been a pleasant experience.
Yeah, what was that?
In Japan, there is a very unique things called the University of Occupational and Environmental Health. I mean, it's
A whole
probably one of the rare university in the world is completely dedicated to occupational health.
Yeah, and you were teaching in that?
And they had invited me for as a visiting professor for a short period. In fact, I was there just 2 weeks, but it was very intense.
Did you get to see the workplaces in Japan and how different they are?
Oh yes, oh yes.
Yeah? I'm sure you had to.
They brought me to workplaces.
Do they really take work differently there?
Well, not so much. I
no,
mean,
but the impression is that they kill themselves at work and they dedicate themselves to work. And is that
yes. But in terms of quality of the environment, the workplace is very comparable. I would say.
Yeah.
One day, let me tell you something. I went to that was in Taiwan.
Yeah.
And during the meeting, an hygienist came to me and said, would you like to see how the asbestos from Quebec is being handled here in Taiwan?
Oh.
Said, wow. So sure, yes, of course, I want to see that, because they were purchasing asbestos from Quebec.
Yeah.
And Quebec was telling these people, if you handle it properly, there is no risk. And in order to do so, Quebec will sell this asbestos in bags, and the bags will be wrapped by plastics. And the introduction was that you take the bag, to put it immediately down inside the reactor. You don't open the bag.
Oh, I see, with the plastic on.
Well, you can remove the plastic, but you take the bag in order to avoid exposure in the environment.
Yes.
Okay, so they brought me to the factory where they were making asbestos cement. And the first thing I saw is that, there are lifts, I mean, these little machinery that...
oh, yeah, that they have then the...
How do you call that? Lift?
I guess...
Work lift, no?
Yeah, there's a name for it.
Forklift.
That's it, thanks.
And so the man arrived with the forklift. It has 2 pins in front, and instead of taking
I see what's happening.
the piece of board underneath this...
It went into the bag?
Directly in the bag.
Seriously?
Yes! And then he will bring this close to the reactors, and there is asbestos everywhere, and then another man will pick a knife and will open the bag. So it was a very bad exposure.
I see. And did he bring you there deliberately to show it was good or that it was bad?
I think he wanted to show me that it was bad.
I see.
He was an hygienist. He knew about it, and he wanted to tell the employer that that's not the way of doing it. So.
and why did the workers not realize? I mean, is there the word asbestos everywhere?
Small shop with 3 or 5 employees, and.
But I don't know. North America now, nobody would go close to that.
No.
But in the rest of the world, still, you think?
Although Taiwan is an advanced society.
That's what I think of. Yeah.
That must have been an exception.
My goodness. Oh my. Well, I mean, because if the politicians have been telling us that it's going to be handled perfectly over there.
Yes,
not
but
really.
That was not what I saw.
How many years ago was this?
Oh, it was several years ago, in the 90s.
Oh, okay. Do you think it's better now?
I'm sure.
Yes, I hope so.
Do we still sell asbestos? I'm not sure that we do still.
Well, I think so. I think that came up last year about whether it would be handled properly in India or China. I think it was one of the issues, actually. Yeah. I think we'll come close off in a few minutes, but I think I just wanted to go back now over kind of the big sweep. I'm in page 5 of my questions here. Sort of for other people I've interviewed, I've asked them how much good did epidemiology do, vaccinations and so on, over the last 3 or 4 centuries. What's made us live longer? And I had a cardiologist here who was asking what's happening in cardiology. Now, how much better off is humanity now because of occupational medicine than they were 100 years ago or 200 years ago? Is that one of our areas we should be proud of in medicine, the occupational medicine for protection of workers and so on, as much as the vaccination people are proud that people are now not dying of infectious disease in childhood and so on like that? Do you see the same level of progress that's been made in occupational medicine, or is it harder to measure and to point to?
No, I definitely see major changes.
Yeah.
Big changes, but in our societies.
Yeah.
Part of today's problem is that the dirty technology has moved to other countries.
I see.
This is a bad thing. If I look at in our North American countries, the workplace is very different than what it was before. And in terms of quality of air, in terms of protection of the health of the workers, is major changes. It's not perhaps so much in the construction industry where they still have accidents and deaths.
Yes, that's right.
But for the rest, I mean, that's day and night. I remember that when I started this, I think the first student I had, I brought them to a factory where they make carbon rods, and we could not see more than maybe 10 feet in front of us.
Oh my goodness.
We were in a cloud, and after maybe 30 minutes, he asked me to go out because he was suffocating in this environment. This is how bad it was. You don't see this anymore.
I see.
Environments are very clean now, and safety and is being placed. Plus, there have been major changes in legislation, in standards, because the work environment is an organized world. I mean, it has legislation, standards, penalties, all these things, and they work and they function.
It's one of I see what you're saying. It's one of the most regulated, whereas our regular environment is less so.
Exactly. Exactly.
Yeah.
Of course, the small shops. This is where we see problems today.
Yeah, cutting corners and
The plumber who works with his brother, we end out in our clinic having a limited level of lead in his blood.
Yeah, because it's private and just small time. So.
We still do see these type of problems, but they come from
in this private
people who are
just aren't
not
working on
too
their
much
own.
worry and yes.
I see. But so it has been a success story then, occupational medicine for humanity in general, I think.
I would say so. And also, we must realize that the work environment, the workplace is completely different today. Right? In the past, it was heavy industry. Today, it's more in the service area. It's more office work. It's more computer work. This has changed a lot.
I imagine still the places I think of as dirty jobs, still a dry cleaning or something like that would still scare me. Right? I mean, I would think that's still not a nice job, and it's probably done by private, small places as well. So. Now, just turning on a little bit to outside of academia, you told me that you still have those colleagues from Boston that you take vacations with once a year and so on like that. Right?
Yeah.
Yeah, and now I know yourself, it sounds like you've worked awfully hard, but I don't want to call you a workaholic because I think that's a bad word. Somebody else told me workaholic is just a question of bad attitude, you know, but you worked hard, right? But
I think I did.
But did you take breaks, or how did you stay sane, and how did you keep, from getting you down? Or was it so enjoyable that you never needed a break?
Well, of course, I like summer times where I go to the countryside and forget everything. And I have a cabin in the wood. And
where's that? Way up?
I like mosquitoes and animals and canoeing and things like that. So it's really, for me, that's major.
Important.
Yes.
Yeah. And you have no
At
cell
some
phone.
part in my career, and particularly when I was chair of the Department of Epidemiology,
oh boy.
I needed
we were
to
a tough bunch.
I needed to take breaks. I take 1 week break every 6 weeks in order to
stay
keep
sane.
up, because
Exactly.
I became tired. I mean, I
I
felt
think
that was a bit too much.
I think it was in the middle of the recession. It was an amazingly rough time at McGill, I think. Nothing was possible. Exactly. But yeah, you don't have a cell phone, but in the cabin you have in the woods. Is it on a lake? In a lake?
It's on a lake, yes.
Yeah, and inside in an island in the lake. I'm not mistaken.
No. It's on the shore of the lake.
Oh, is it?
Yes,
Yeah.
yes.
And but no electricity there.
No electricity, no television, no
cell phone.
No cell phone. It doesn't work over there because we are in between mountains.
I see. Yeah. And
there are foxes and beavers, bears.
Yeah. And when you're tired in the evening, or would you listen to music, or do you read a book, or what do you do? You're so tired after the day, you just want to sleep. Yeah.
I like that you see it this way. I'm so tired in the evening that I don't do much. I lay down.
That's a great way. Yeah.
Yes.
Yeah. But you still books. I'm curious what books.
I am not a big reader of literature, but I am always fascinated by things like medical physiology. I mean,
What?
you would find this crazy, but I enjoy very much reading a new book in medical physiology and see that the evolution, the development, things are really progressing a lot. I mean, everywhere.
Oh yes.
Biochemistry,
And you're
genetics.
Able to, and you're able to keep up with all that technical stuff. It's
sorry.
You're able to keep up with all the technical areas, or it's a very
Well, of course, I read books that are big
Simplified.
of vulgarization.
Yeah. It's simplified a bit.
But good textbooks are amazing with drawings and
I see. And does
tables and figures.
Does this come into your? You still work in the occupational clinics, right?
I do 1 day a week of clinic.
Yeah.
I return to clinic. You know, first of all, I am a physician. I am a doctor.
Yes.
That is deep in the skin.
So that's why you continue to.
After I retired, I kept return a little bit to the practice of medicine 1 day a week.
Yeah.
And I fully enjoy it.
You were telling me a story of a patient that was getting what was it? The patient who went in the NMR machine and was having headache. No.
Yeah.
What was
that? That was to illustrate the bridge between my reading and very special situation. A patient came to me because he was worried that he reacted to electromagnetic field. And no, usually you don't react to electromagnetic field. But he told me a really unique story. He had resonance magnetic imaging of the brain. And he went in the machine and they did the MRI.
Oh yeah, that's a very noisy one, right?
It's a noisy one.
Yeah.
It's a big
huge, like being
magnet.
inside of a jackhammer.
They put your head in the magnet and they shoot.
Yeah.
First, the magnet will reorient all the molecules in the body, and then they will shoot a radio frequency so that this will vibrate differently with all the different density of the tissue. So they take a picture of that, and they can see all the components of your brain. Well, that's the usual technique.
Yeah, exactly.
But in this particular case, when they bring him out of the machine, he was paralyzed for 30 minutes.
Entirely?
Yeah, he could not move. And then slowly he would recover the movement. And then after half an hour, it was okay. And so I realized that when you're on the magnetic, in the machine, your electrolytes that are electrically charged will be pulled in different direction. So potassium will go in direction, and calcium and sodium, because these are you have electrical charge, and we put that in the magnet. And so some people, they have genetic weaknesses that they don't know of and nobody will ever find out, but that slowed the passage of these electrolytes in what we call channels. So they have what we call channelopathy.
Oh.
And so this man, that illustrates that he had this defect. And so when they bring him out of the machine, it took a longer time for these electrolytes
to come back to
the normal.
I see. And that was causing.
And then he recovered completely.
Yeah.
But
how long did it take you to figure that out?
Well, I guess it's between
You knew it already?
my knowledge of the technology plus my reading of medical physiology.
My goodness. And has there been other cases like that, or is that mentioned in the textbook, or you figured this out?
I have not seen this anywhere else. I have not seen it. It's not yet described.
You should describe it. I hope you do. Seriously. Yeah. Well, it's fascinating to see somebody keeping up and integrating all this at this stage. Yeah, that's really something. Yeah. So let's just I'm asking students are going to be asking you, what should they be studying now and how should they be preparing themselves for careers? And we'll just end with that of any advice you have for students about how to choose what to study in health research or in the occupational health research in particular, but even in epidemiology research in general. Is there any advice you'd give to them? I mean, I think just listening to you is great advice by itself, but is there any specific advice you'd give them about what they should be, what topic they should be choosing? How should they be preparing themselves to their skills for getting good at this? How should they work? What would you say?
Well,
that's a big topic, obviously, but
when I have been using epidemiology as a tool in research.
Yeah.
I think a young student should be clarified. You can either you want to become an epidemiological scientist that will work on improving the discipline of epidemiology on one hand, or you can use this wonderful tool that is epidemiology to research on questions, on hypotheses, on something that you want to investigate.
Yes.
So I am of this category.
Yeah.
I know there are
There's
other
only
people
very
in the
few
other
of the
category.
others. Yeah,
That's
yeah,
great, but
yeah.
that should be made very clear to a student who start a career.
I see.
If a student is in
Your
the
mode.
orientation that I have been,
Yes, exactly.
make clear that what you want to study. Have a very clear idea, good structure of your hypothesis, good questioning, a realistic one that can be tested, and then use your tool to do it. Unfortunately, a lot of people will do research on questions that are not well defined or are not of importance. Life is very short.
Exactly.
When you go in epidemiological studies, you engage into a long enterprise, and you don't want to spend too many years
on the wrong stuff.
On the wrong stuff. Another thing that I'd like to do, in our time, we have a very naive notion of causality, I think. And today, we realize that causality is something trickier, that there are many dimensions. So when you create an hypothesis, don't forget that somebody can see your same question differently, or there can be, the mechanism can be more complex. And work your epidemiology in order to contribute to untangling these complex questions, and not just be very naive and say, oh, I'm going to ask people if they have headache and if they eat whatever, donuts. I mean, you can study headaches and donuts, but at the end, I mean, you may end up
so you're saying
waste your time.
Life has gotten more complicated, the questions have gotten more complicated?
The questions are more complicated. We should not do epidemiology in isolation. We should consider contributing with other people
who have other
expertise. To clarify this.
The people with expertise in the other...
Expertise in other disciplines as well.
Yes, I see, yeah. And, but I think the most I would get from them is being curious, being...
of course.
Must be the biggest thing, right? And being committed to the service of the public. This is what I get from you, is so much you're serving the public, right? Ultimately, your work.
Well, there's service of the public. There's also the rigor of research is always there. You cannot compromise on that. I mean, no, you cannot compromise.
So that's where the epidemiology comes in a way, the thinking, right? Yeah. Yes. Well, Gilles, this has been really, really fascinating, and I want to thank you on behalf of all the viewers, I hope, of this, for being such an inspiration to us all, and for such a wonderful description of how exciting your career is and a career in this area is. And we wish you many more years at that college and in life and in your work, and continued good health and happiness, Gilles. Thank you very much.
Jim, thank you for giving me this occasion of expressing myself. I'm a bit, I feel I spoke too much of myself in this.
Oh, not at all.
But your initiative of inviting old people like me to review a bit of their career is a wonderful initiative on your part, and I want to congratulate you for doing it.
Well, no,
I hope it will be useful to someone.
I hope so too. Thank you very much, Gilles. Good luck.